All right, so today is a chapter all about the medical considerations of older adults. We get our PowerPoint, we'll be good. All right, let's do a really quick overview. Older adults experience many of the same health conditions as younger individuals. They don't necessarily, we always seem to think of older people as sick and unable, but a lot of the same stuff that we face, they face too. They get colds every year. They get any of this stuff, they face it the same. They might be at higher risk for some stuff like certain types of cancers and whatnot, but overall, their health and their health conditions are very similar to a younger person's. There is an idea of something we haven't talked about called silent symptoms, and that's a term you guys definitely should know. Silent symptoms are things that you really don't see. Some common stuff is like CHF or UTIs, pneumonia. A lot of these can be very, they could be progressive, and the person actually have a lot of different deficits, but they're not going to present the same way. So like with pneumonia, you can silently aspirate and get pneumonia, and they may have a small, like just a wheeze, and they actually have a pretty severe case of pneumonia. That happens a lot to people. With CHF, another silent symptom is swelling. They might have a little bit of swelling, but when you come and see them for whatever reason, they have their legs propped up, whichever, and you don't see it. But, by the end of your session with them, they might have that swelling come back. That's another idea of a silent symptom. It's just things that are not as prevalent. They're not like hacking up a lung with pneumonia. They're just kind of got a little bit of a wheeze. So UTIs is that change in behavior. Do you remember us talking about that, how it can be a sudden change? They might not be acting like weird, but they're not acting like themselves. That's another silent symptom. All right, so some normal age-related changes in physiology and psychological factors can affect development and outcomes of diseases. It depends on what all is comorbid with a person. If they have more things wrong and they have a lot of comorbid diseases and disorders or whichever, it's going to be a lot harder to motivate them. It's going to be a lot harder to work with those types of people. And then the severity of those conditions is really going to play a huge factor. UTIs can, we talked about them a lot, but when you really see how much it can change somebody, like in the blink of an eye, it'll really, stand out to you. Some people could be feeling really, really great, and then, it just gets to a certain point with them, and then they feel awful. My grandma, poor thing, keeps UTIs all the time, and her trigger, she always knows if her back is hurting her really, really bad, more than normal, she has a UTI coming on, so she's learned that. But she'll go from, cooking her all of her meals, laundry, doing everything she can, and then all of a sudden, boom, she's down and, knocking on heaven's door. And it takes a lot of different tries with antibiotics to try to get it over or to clear it up. But, the older people are so susceptible to something like that, and it really can affect them. Like a lot of younger people can have UTIs and, they take an antibiotic good. It doesn't really affect their day. But older people, it will literally change their whole personality, put them in a lot of pain, and you'll think it's something way worse. People can actually die from UTIs if they're not caught. It's an infection, so they can go septic if it's not treated in time. And a lot of patients do end up dying from UTIs that are untreated because they can't find an antibiotic that will actually kill the bacteria. After they have them so many times, they run out of antibiotics and they can't find something that's really going to take care of it. Sometimes it already escalates from like pills to needing IV medications. It really just depends on how many occurrences has happened. So UTIs are a big deal for older people for sure.
Why are they getting so many?
Because everything's not working properly. UTIs a lot of times happen because of they're not being able to fully empty their bladder. So urine is just sitting in the bladder and collecting bacteria. One good tip to teach older people is that when they go to the restroom, sit a little bit longer than what they think they need to, and keep pushing to try to push it out. Because if it sits in there, they're going to get a UTI. It's just stuff not moves as well. Doesn't move as well. Yes, everything starts to get weaker. And it doesn't become as more like the bladder doesn't contract as well to let all the urine out. So it takes a lot of extra effort. One good thing to keep fluids pushing is a lot of water. Just say you need to be drinking water all the time. It feels it's kind of the idea of it. They're still not getting it all the way out, but they're kind of replenishing it, or pushing good fluids through the bladder, and it helps to keep that bacteria rate down. Sometimes it's inevitable. Sometimes it's a hygiene issue too. If they are incontinent and they're wearing briefs, they can also get bacteria that way too. If they're sitting in feces or whatever and whatnot, it makes it much higher. Of course, women are much more prevalent to UTIs at a much higher rate. We'll talk about that in a second, though. All right, so the probability that there are multiple pre-existing conditions can complicate intervention. Same idea of comorbid disorders. Acute conditions can have a significant implication for morbidity and for post-care function. What do you think that means, Isaiah? Acute conditions can have a significant implication for morbidity and for post-care function.
Because acute conditions are sometimes just that thing that happens that puts them out there, just kind of give up.
It can absolutely just wipe someone out. Like something that, what would be an idea? What are you thinking of? When you think of an acute condition that can do that, what comes to mind? Breaking a hip? Yeah. That would be an acute condition. What about another? That's kind of like an acute fracture. What's a condition that might be acute other than UTI? Yes. Yeah, I guess. Yeah, I didn't think about that. I was thinking pneumonia is another really common one, but yeah, the flu and COVID could be that absolutely affects somebody's function after the fact, right? Yeah, UTIs. The consequences of hospitalization can be very significant if it is a long hospital stay. Do you remember the rule of thumb we taught you guys last semester that every day in bed, how long does it take to get that function back? If you lose muscle strength and muscle tone, how long does it take? Huh? Not quite that long. Thank God it's not that long.
4 days.
3 to 4 days. Yep. Roughly 3 to 4 days to gain that muscle function back of just somebody laying in bed. Now, this is where we educate doctors, we educate nurse staff that if the patient is able to get up in any aspect, even if it is just helping them to go to the bathroom, that significantly impacts their therapy rehab potential after the hospitalization. Like in a major way, just getting up and going to the bathroom, or just getting up and sitting in the chair that's in their room and watching TV for a couple hours. That kind of stuff has huge implications on, how well they're going to do outside of the hospital. We're going to talk about a few different diseases that are prevalent in older people. Some of this is going to be like, there's one on here about stroke. I'm not even going to read that slide or go over it because I think we've talked a lot about strokes by this point. All right, so cancer. Typically, mortality is much higher for older adults. They're not able to treat or take the treatments, as well as younger people are. But it's also in combination with other conditions, higher rates of diabetes or heart conditions, whatever it may be. There's underlying factors. And a lot of times older people pass away from cancer, or not necessarily from cancer, but from the other things with the combination of cancer. So it's important to keep that in mind, that what they may pass away from might not actually be the cancer itself. Choosing the right kind and amount of treatment is very challenging for older people because As you guys have seen, chemotherapies and stuff are very, very hard on patients. It's that much harder on older people. So it's really hard to choose what is the right amount. What's the quality of life? My grandma, I talk about her a lot in this class, but she amazes the crap out of me. She's had everything and her brother to go wrong with her. She's had strokes, heart attacks, you name it, stomach cancer. She's had everything. And literally like 2 years ago at 85, she had 8 rounds of chemo to beat stomach cancer. It was really, really, really hard on her, but now she lives completely independently. I mean, she's an outlier to everybody. Most patients that I've worked with that are in their 80s, they try to run through chemo treatments. A lot of them don't. A lot of older people just decide not to go through those types of treatments because they know that will be it anyway. A patient preference should be taken into account in selecting treatment. Like if a lot of the cancer patients that I've had experience working with, I try to make it as personal as possible for them. Like if I need to work on some strengthening or balance or whatever, I try to find some activity that they want to do, especially in home health. One lady, she really liked to do her own laundry and cook her husband a meal. So we would, that was part of our treatment session. We would either do laundry that day of the week because I saw her 2 days a week, or I would come later in the day, plan it, and we would work with comp strategies and energy conservation or whatever it was and help her cook her husband dinner. She really, really enjoyed that. It made her look forward to working with us. Now, she had, stage 4. It was pretty much terminal, and she's actually passed away at this point. But it was that idea of I knew she wasn't going to get better, but I was trying to give her quality of life a boost, Occupational therapy and PT should emphasize support of meaningful function and give them psychosocial support as well. That's just that idea again of making sure that you make it personal with them. Diabetes and obesity. It may be diagnosed later in life, or it may be a chronic condition. We all know that all ages are affected by diabetes and obesity. Metabolism, they might need dietary or medication needs, but it also slows down later in life. That's why you do see diabetes and obesity. They don't process food as well. Their metabolism doesn't keep up like a younger person's does. There are long-term consequences for that kind of stuff, though, like heart disease, retinopathy, neuropathy. All these things can come later in life, especially if they've had these conditions for a long time. But we're going to work on things like managing diet, managing medication, educating them about those long-term consequences, and providing any kind of emotional support that we can. Again, we're going to talk. Here's your statistic that, or not really a statistic, but just knowing that women, especially women that have dementia, are at much, much, much higher risk of developing a UTI. Why do you think women, and then especially women with dementia, are at higher risk? Hygiene. Hygiene is the #1 cause of UTIs. Some women get them, and there's just literally nothing that you can do about it. They just are prevalent, but if a woman has dementia later in life, they're at much higher risk. It's difficult to diagnose it because of the silent symptoms. You may, especially if they have dementia, how do you tell if somebody's personality is different or if they're just having a bad day? Dementia can make you cause or do all kinds of different weird things, right? That we've talked about. How can you tell the difference between a dementia episode or just a bad day and an onset of a bad UTI? Do I know any of the other warning signs of a UTI? Frequent urination, that's one of them. Blood in the urine. Fever. Right? You know any other warning signs? The urine smells bad. And you may painful, it burns, all of that stuff. So if your patient is complaining about it, burning when they pee and all this other stuff, you need to have them checked for a UTI. That's like gold star. Remember that always, because that is 99% of the time the issue, especially if there's a sudden change and they're not feeling well. But it's really hard to diagnose because of the silent symptoms. Somebody with dementia is probably not going to remember to tell you that it burns when they went to the restroom. Unfortunately, a lot of time, I'm telling you, is the smell. And you'll learn that. It sounds gross and sounds weird, but there's a smell. If you walk into a patient's room or you walk into their house or wherever you're treating them and it smells like urine, there's a pretty good chance that there's a UTI going on, unless there's just really bad hygiene. And I had one fella that I called APS because he was so unsafe at home, but he lived in literally lived, slept, everything in a wheelchair, refused to go to the hospital, would not go to facility, had capacity, but would not. I mean, I called the social worker in, I don't know how many times, to try to come in and get him out, but he refused. And what he did, I found this out after I've been going to his house for a while, is he would pee in sweet tea jugs. And then he could only use really his living room and his kitchen. He couldn't hardly get to his bedroom. It was a big cluster of stuff. And he would come out, open the front door, and dump the pee on the front porch. And it was wintertime, so it would freeze on the porch too. And one day I walked up and I said, man, if this house just constantly smells like pee all the time. And sure enough, I looked over and there it was a frozen yellow puddle all over his mat. And I said, well, I know what this is. So I addressed it with him. Oh, yeah, I'll stop. He could not get to the toilet. He couldn't get the only place that he could get to. He could get to one toilet, but it was extremely, extremely unsafe. But, I mean, what other choice does he have? He would dump his urine out. I eventually convinced him to dump it down his sink because couldn't fall. It was really hard spot because I don't want to say, okay, you need to dump it down your toilet, but then he'd fall trying to carry a jug of pee to transfer to the bathroom. So it's kind of a catch-22. No, I realized that was a terrible hygiene thing. What else can you do? It's right. It still made everything smell like pee, but it was the same jug, so it's not like it was hygienic. He would open it up, dump it on the porch, but it was a call that I had to make because I don't want him transferred he should have went to a hospital or to a facility and went to an adult living facility and been safe, but he refused and he had capacity, so it's kind of a catch-22. So we haven't talked a whole lot about infectious diseases, but rates of infectious disease are higher in older age. A lot of people don't know this, but in skilled nursing facilities is actually one of the highest prevalence of sexually transmitted diseases. It is what it is. I've worked with a lot of patients that were swingers back in the day and all this stuff, and they wanted to continue that lifestyle in a nursing home. If they have capacity, they have capacity and do what they want. It's their house, technically. So, the higher rates of infectious diseases are caused by a lot of chronic conditions, a decline in their immune function, immunosuppression because of a medication, and we're going to talk about that here in just a minute. HIV infection rate is increasing like a lot in the older population, both from drugs and other stuff. All right, so nutritional deficiencies and oral health is very common later in life. Oral address needs to be addressed right off the bat. That's one of the very first things. If you go in after an evaluation and you're like talking to the patient, just trying to get a better idea post their eval of how they're doing, what they do in a day, oral health should always be one of the things that you check off. If you have dentures, how do you clean them? Do you brush your teeth every day? All this stuff. That really needs to be a check off in your head to make sure, because if they have poor oral health, that can affect a lot of different stuff. You can get heart disease from poor oral health, dietary issues, all of that stuff goes down if their oral hygiene is bad. But you really have to identify that cause first with nutritional deficit. It might be that they don't have money. Many a times we go pick up a Tudor's biscuit and take it to a patient's house one day because they didn't have any food. I just felt bad for them. They had Meals on Wheels, but that's one meal-ish a day. I think 5 days a week helps. But a lot of times you can't get on that waiting list, or you're on that waiting list, but you're on it for years. You got to eat, right? So it just is what it is. So home health is a different ball game. And I know who was I talking to? I think it was Jennifer about going to home health, and Maggie's going to do some home health, I think, on hers. But it's a different ball game. I feel in my heart that OT's true spot is in home health compared to a lot of places, because you're in their home working with what they have and teaching them how to do things in their environment. It's not like, skilled nursing and all that, that's great. And outpatient, it all has their places. But as far as like the root of OT, I don't think you can get more of a holistic perspective. Now, that comes with a price. Some people live in some crappy conditions, but, people have a right to live how they want to. So.
If they don't have like SNAP or something,
Mhm.
would you help them?
Yeah, absolutely. What I always did, we had a really good social worker that worked with us, and I always referred them to her because she was very comprehensive of, okay, there's this. Now with y'all's background, you know a lot about that stuff. So that's a good, in with patients of knowing the system and how that works. You're allowed to do that kind of stuff for sure. But I just referred it to the person that knew all about it, knew all the different things. When in doubt, I always referred to the social workers. There is, and this is new. Our home health company set up, I can't remember the company that they went with, but they would do a grocery delivery service. Like Kroger does delivery now, Walmart does delivery now. Problem with a lot of people in West Virginia, though, is they live outside those delivery ranges. Churches is another really good one. I don't know that much about SNAP. If they do, that's just EBT cards, right?
Yeah.
Yeah. I really don't know that much about that, how they could use it. Sometimes caregivers are the best, like even if they're not there to take care of them, a lot of times you can talk to children or family members to go get their food and bring it back and work a schedule out with them. Sometimes I've done that too, like called their son or daughter and be like, hey, so-and-so is hungry and you live 15 minutes down the road. Do you care to set up a schedule with them to get them groceries? They're having all these health issues because they're not getting enough food. And, sometimes it's as simple as that. Sometimes it takes a lot more. I've even reached out to their churches and stuff and said, hey, so-and-so really just needs somebody to get their groceries for them. Can you do that? And you got to be creative, All right. So this is a new topic, frailty syndrome. This is exactly what it sounds like. This is where somebody is very frail, very weak coming out of the hospital. They have a low level of physical activity. They don't want to do a whole lot. They still don't feel good. They made it. They beat whatever they were going to do at the hospital, but they still have a very low level of energy, and a lot of times an unintentional weight loss. You guys have probably seen this before, visiting a family member, an older family member after you get out of the hospital, that really just down sense that they have after that. If it was especially a really hard hospital visit, like a lot of stuff had to happen. If something really bad, extreme has to happen, like open heart surgery or whatever, that's another big thing that makes them high risk for this. But medications don't really help. Exercise kind of helps. It's kind of that idea of, you ever heard like the more sleep you get, the more sleep you need? You ever heard that saying? It's kind of like that, but in one sense. But it's if you can get them moving in some aspect, it helps to get over this a lot faster. Post-hospital syndrome is extremely similar, but it's not necessarily affected by age. Okay, so frailty syndrome is for older people. Post-hospital syndrome is anybody. Okay. All right. So medications later in life. There's a couple terms that you guys need to know. Pharmacokinetics. This is how a drug affects the body. like ramping up their immune system or, antibiotics, that kind of stuff. Pharmacodynamics, this is the actual like product of it. So this is what the drug does to the actual body. So benzos, it would be an idea of how they help reduce anxiety and help with sleep. Okay? Does that make sense? Yeah? One yes?
Medically
Right.
prescribed for.
Well, it's one is what it does to the body. One is the outcome of what it does. Does that make sense? So the pharmacokinetics is about the body's function. It's ramping up the immune system. The dynamic one is you gaining immunity, the goal of it. Okay.
Think of it as in one is how it affects the body, and one is the symptoms that come from it, or the lack of symptoms.
One is the physical thing that it does to your body. The other is what the outcome of that is. Okay, so what? This medication decreased your anxiety, but the outcome of it, the dynamic part of it is that you sleep better. So you're being diagnosed. So you go into the doctor and you say, hey, I'm having trouble sleeping at night. He finds out that you have anxiety. He prescribes you this medication for anxiety, right? The kinetics part of it is them ramping up whatever dopamine or however they're going to address it to bring those anxiety level down. The dynamic part of it is the outcome of that. You are able to function better. You're able to sleep better. That's the second part of the medication. Okay? Does that make sense? Okay, cool.
What about the side effects?
What do you mean? Well, that's what I'm getting ready to talk about, the side effects. One of the most common things and common issues older people face is polypharmacy. Polypharmacy is where older people take all these different drugs. They call them their morning Skittles, their morning M&Ms, whatever it is. They take all this stuff, and they all have different side effects. And then they have medications for their side effects, and it's all this stuff working together. And it's crazy. Medication management is really difficult with an older person. Some with younger, but really with older people. And you might not think that this is common, but it really is. Physicians will mess up people's medications in a heartbeat. We had a system in the home health company I worked for that the first thing you do is take their vital signs, ask them, and then before you do any treatment, you always ask them, do you have any new medications that you're taking? No matter what it is, if they're doing an over-the-counter PRN thing, it doesn't matter. If they have a new prescription drug, everything goes in their chart. So what you do is you would type in all that, their dosage, everything that they were taking, and then it had a little button you would click, and it would run what's called a drug-to-drug interaction, and it would let you know if there was this drug will react with this drug and cause this bad side effect. It's really cool. You can do that on your own. There is a drug-to-drug reaction. You can Google them. There's all kinds of search engines like that you can do. A lot of times patients will say, I got this new medication. It's making me really, really sleepy. You run the drug-to-drug interaction. They'll say, oop, boom, these two drugs react and cause drowsiness. But doctors will do this so often. I can't even tell you how often I've had to call. And it's weird because in home health, they require you to call and talk to the doctor or leave a message for the doctor and tell him, hey, you messed up. There's an interaction here. This reaction is really affecting this patient's sleep. You can't, and, they'll call and say, oh, yeah, we may have went too high on this dose, blah, 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 and then they'll fix it. But talk about a power move. I always hated doing that because I was like, man, what is it my place to do it? But if the patient is really, not doing well and having bad side effects, their doctor needs to be made aware. If they have a slow kidney or liver function, you'll often see their dosages are much lower because they are much higher or much more prevalent to an overdose by something just simple. Like a normal dose for us that has normal kidney and liver function can overdose somebody who has poor liver and kidney function. So that's definitely something to take into account. Oh, and medication management. I've got a video about that of different adaptive equipment. So we'll talk about that in a minute. For pain management, remember, pain is not an expected or normal part of aging. It is the fifth vital sign. And if anybody is complaining to you of pain, just don't take it into account that they're older and they're always in pain. Really take it and address it. Okay. It's easy to do that. Like, oh, my arm, oh, my back is hurting me today. Oh, I've got the aches and pains. That's still not normal. Like, there's an issue causing that. We don't consider any type of pain normal. So it needs to be addressed in some form or fashion, okay? Opioids are, of course, common in West Virginia. If a patient has taken an opioid, they can often become sleepy. A lot of times are not tolerated at all by individuals. If my grandma, she has terrible back pain. If she takes an opioid, she is nuts. Like, it's like she's high as a kite, and it's really something to see. But, some people can take opioids and take them every day, and you never know. It's very different. If you have a patient who starts an opioid, make sure to educate them that they need to monitor their symptoms and their caregivers. You need to be really aware of changes, okay? Because they can prescribe a lot of different stuff for pain. Opioids are fading quickly as far as being prescribed. They're on the streets a lot, but as far as actually being prescribed by a doctor, they are fading quick. NSAIDs, does anybody know what those are? Or an example of one? Ibuprofen, Advil. Those are very hard on people's stomachs, especially if they take them all the time. So if somebody is taking that over the counter and they're saying, hey, I'm having really bad acid reflux, that's probably what it is. A lot of people, it jacks your stomach up. A lot of people have stomach issues from Advil and stuff. All right, so we have moved our approach is all about the non-medication type approaches. We had a meeting with the Attorney General a few years ago, Patrick Morrissey, about the opioid epidemic. And West Virginia has now completely changed on what can be prescribed first for pain management. And occupational therapy and physical therapy are right there at the forefront of being prescribed first. Oh, you have lower back pain? Okay, try chiropractic care, try occupational therapy, try physical therapy. You have to try all these things. It's huge loops you have to jump through, or hoops you have to jump through in order to get to getting prescribed an opioid now, which is a good thing for some people and it's bad for others. But, overall, we have totally shifted gears in West Virginia to try to get away from opioids. Some, believe it or not, older people will abuse their medications, especially if they are in pain. They'll take way too much pain medication, start acting funny. You have to be aware of those types of behavior changes. If someone does not have a UTI, you can almost bet that the next time or the next thing that you need to ask is what medications did you take today? Because there's so many side effects. I mean, Lord, every medication commercial that you hear on TV, 90% of it is reading off side effects, right? You guys know with medications that even if it wasn't a side effect of the medication, but it happened to somebody while they were in the trial, they have to list it. So when you hear death on a lot of those, if somebody took, just for sake of example, if somebody took a Claritin in the clinical trial and walked outside and got hit by a bus, they have to list death as a side effect of Claritin. Do you know that? So it really does not matter at all what happens. And it could be somebody had a heart attack, but they had a history of CHF because they make you do randomized trials on medication. So it could just be somebody had a bad heart anyway. And Claritin had nothing to do with it, but now they have to list it as a side effect. Isn't that wild? All right. So again, what we're going to do as far as medication is we're going to assist them in learning and maintaining medication schedules, teaching them and providing them assistive equipment like pill boxes, phone-based reminders, all of this stuff. Observe for main and adverse side effects. And I'm going to show you some of this adaptive equipment now.
Hi, welcome back to the Hot 5 Tips and Tricks series. Today we're here to talk about medication management. My name is Jennifer Ruoff. I'm the Director of Occupational Therapy Clinical Services here at Fox Rehabilitation. Today with me is Rachel Reed, the Director of our EHR. So some of the things we're going to discuss today are different ways that you can utilize some adaptive equipment regarding medication management. So a lot of the times when we're going into our clients' homes, we find that they have a really hard time managing their pills and organizing their medications. So there's a couple different things out on the market. There's actually a ton of different pill organizers. I have a couple options to show you, but you can see the difference in these two. The contrast is a little less on the purple one. The font is a little bit smaller, but the container size is bigger. So this is for someone that has difficulty with fine motor coordination and needs a little bit of a bigger area to be able to manipulate the pills in. This would probably be more beneficial. The contrast on this one, the letters are white, more bold, but a little bit of a smaller container. So maybe if a client has more visual issues, this might be more beneficial. This one is just a very simple white container that allows you the ability to go through. It also has braille on it, which is really nice. So if someone has visual impairments, they can utilize this. If someone needed more ability to organize their pills for AM and PM, this would also be beneficial. They have some you can even remove the containers, but this allows them to set up their pills a week ahead of time and gives them the options for both AM and PM. And a lot of your education would be related to either coordinating it to the color, having them understand the color, or having them understand the sign of AM and PM. And then this has more letters for the days of the week. Rather than just the initial, it actually has part of the word spelled out. This is the simplest one, morning and night. That if someone wanted to take them with them, or they were going out to lunch or breakfast, or they were going to be gone for the day, they would take this with them.
So I was going to say, I actually like this one the best because I find that a lot of times our older adults have medications from AM and PM, and I like that it diverts the confusion for them because you have to have it like strategically placed in order to get the PM meds. They have to be on this side versus the AM meds on this side. So it allows us to avoid that confusion. What I don't like, and I don't know if you like, the ones that have like a 4 where it's like it's too overwhelming, and sometimes if you're not taking medication 4 times a day, which a lot of times it's really just morning and night, I kind of try to get rid of those ones because there's like empty rows. So those are the ones that I'll say like morning, midday, like lunch, night. I don't even know what they are. Yeah.
And something too that's helpful with this, that we printed out as kind of a guide, would be actually putting the color of the pill, the size of the pill, and what it is, so that when they are setting up the actual management of their medications, they can take them out of the bottles and lay them out. That's usually something that I'll do as a treatment session that provides them with skilled care and how to set up their pill organizers so they're not reliant on somebody else. When you go out to see a client, you notice, or you talk to them and they say, oh, I didn't take my pills this weekend because my daughter was away and couldn't set them up. Is there something I can do to help them to organize that to be a little bit more independent? So that's really helpful to have that sheet of how they can maybe independently set up their own medication.
I also use this sometimes because sometimes they don't know what they're taking, and they're like, oh, I don't want to take my medicine because I don't know what it's for or which pills I'm taking. And I've even taken to this next step where I would say, okay, well, your Aricept is for your dementia, and I would put the reason why. And so if you have somebody that is like resistant on taking meds because they don't really know why they're taking them, I find this is really useful too.
Yeah. Awesome. All right, the next one, just a simple handy dandy dry erase board. I'll use this for different reasons, whether it's tracking on a daily basis, pills that they have taken or pills that they have to take. Also, too, side effects. If I have a client that say they take their blood pressure medicine and they feel shaky afterwards, so they're feeling dizzy, I'll tell them, write down everything that you're feeling, whether it be in a dry erase board or on a journal, and then we can kind of go back to it and reflect on, are there are some medications that you're taking that you're not taking them at the right time. You're not taking them at the right dosage, that you have to eat with food or drink with water, that you're not doing it. So this is a good resource, nice contrast, super simple.
Cool. So I have some items over here as well. One of the things that I wanted to show was that sometimes some pharmacies, you can ask if they have any special labels, because a lot of the pharmacies are starting to use more of a visual rather than like written instructions on their medication. So if you can see in this one, it has morning, midday, evening, and bedtime. Those are probably the four. Yeah, and it'll say how many tablets. So it says morning 1 tablet and evening 1 tablet. I think that's just a nice, easy visual cue than it being written instructions very tiny on the bottle. So I think that's really helpful. So I would just talk to your pharmacist on what options they have that can assist you in that you can assist your clients in taking medication. Another one is a sheet kind of like this. So this is a medication list. With the older adult population,
I make those with a
we really
lot
should
of
be
patients,
urging them to
the
have
medication
a written
list.
of the medications and the dosage that they're taking, the route of administration, and the frequency, so that they can carry it from physician to physician, different doctor's appointments if they go to the ER. A lot of times I really encourage my clients, and this is, again, another treatment session where we'll go through the medications, write them down on the list so that they can take it with them from physician to physician. Because sometimes there's not this great communication. So you may be going to a cardiologist to get a blood pressure medication, but you're already on a blood pressure medication from your primary doctor. So this is really good to you.
Something else I do with this is I have every client, it sounds silly, but I have them put something on their refrigerator to say, my medication list is in my freezer or wherever it may be, so that it's easily accessible for if EMTs ever show up. The first thing they say, what medications are you on, or what diagnoses do you have? Do you have anything that I should be aware of? If they're not conscious and something happened that they're not able to report that, they can kind of look for that sign. So either hanging this on their refrigerator, or if they don't want it visible to people coming in and out of the house, they could have a sign saying that it is located in their freezer, and just literally rolling it up and putting it in a water bottle or something that the EMTs can kind of distribute and have.
That's a good idea. The last item I have is a pill cutter. And so this, before you change the form of any medication, you want to have a conversation with a pharmacist or making sure that it's appropriate for you to either cut the pill or crush the pill if the clients are having a hard time taking the medication. Obviously, you can't do these with gel capsules, but if you have a medicine that the client's really having a hard time swallowing, you can get these at your local pharmacy where they can cut the pills. It's nice because the blade is inside, so it's going to prevent any issues from like them cutting themselves. And then also what can be done if your client's having a hard time is that they can crush the pills. And then sometimes you can even take it a step further and put it in like jelly and put it on some toast. For anybody who's resistant to medication, so sometimes you may have a hard time with, dementia client who doesn't want to take the medication, kind of knows that even if you cut it, it's medicine, they don't want to take it. You could crush it and put it in jelly, peanut butter, put it on toast, and they'll be able to eat it. And they're taking the meds and not really knowing it. I found that to be really successful. Again, you want to make sure you talk to the pharmacist, though, to make sure when you're changing the form of the medication that it's appropriate. And just having a conversation, like I always educate my clients to have a conversation with their pharmacist. Every once in a while, anytime they're prescribed a medication, the meds that I'm on now and the med with this new one, is it okay? Is there any contraindications, precautions I should know about? Really just having an open line of conversation with their pharmacist, that's why they're there.
And a lot of pharmacies have a brown bag program that if you have medications that are expired or medications that you were on before, you do have the ability to use this brown bag program that can allow someone to go through your medication and then package up the medications you no longer use and dispose of them. So that's also a pretty cool resource. Cool. So yeah, that's it. We look forward to giving you guys some more tips and tricks on our next series.
I'm sure you guys have seen a lot of those anyway, right? There's some other really cool ones.